Now my talk is, there's a disclosure that this particular talk is being sponsored by Sanofi, and the slides have been given to me. I'll be going to, I'll go talk on those particular slides, but we have some questions that will be absolutely beyond the topic of my talk. You can have any discussion on the particular topic, and I have been instructed by Archana to finish up this talk in 15 minutes. I'll try to do it in 14 or 13 minutes. Nevertheless, when you sit continuously for a long period, it may increase the risk of obesity and diabetes in future, and that's why at the end of my talk, I'll expect all of you to get up, have some claps, so that you keep yourself away from non-communicable ailments like diabetes. So my talk is dissecting importance of rapid-acting insulin analog in type 1 diabetes. Insulin therapy in type 1 diabetes and unmet needs, we'll try to cover that. What are the evidences we have for glulysin, which is a rapid-acting analog, and whether we can use this particular molecule for insulin pump, and do we have any evidences on these lines. Insulin therapy in type 1 diabetes unmet needs, I feel we are listening to multiple speakers across. Very few of us have achieved HbA1c of less than 7, and these are the targets. Fasting should be less than 170, between 170 to 130, post meal should be 90 to 180, bedtime 80 to 140, and HbA1c should be less than 7 in all type 1 diabetes. Unfortunately, less than 20% of these type 1 diabetes have really achieved this, and this is still a dream for many of them. So target is recommended for person who have access to analog insulin, advanced insulin delivery technology, and ability to regularly check their blood glucose. Higher HbA1c of more than 7.5 may also be considered in view of those type 1 diabetics who have increased risk of hypoglycemia, or who have associated hypoglycemia unawareness, or those who have associated complication. Insulin therapy, now this is very important. That insulin in a normal person is being secreted in two forms. One is a basal insulin therapy, which is throughout 24 hours at a basal rate, at a specific rate, and this is continuous whether you take the meal or whether you don't take the meal. The basal insulin secretion from the beta cell is continuous. And then you have a bolus insulin secretion, which is in response to a meal, that is at the time of breakfast, lunch and dinner, and maybe even if you have some high tea here. So insulin therapy has to be physiological to successfully reach the goal of a near normal glycemia. So if you want to achieve the physiological demand what your own pancreas or beta cells they secrete, you have to try to use the insulin which matches this physiology and control postprandial peaks, as well as the basal insulin for the fasting blood glucose and the basal supply of insulin throughout 24 hours. And that is why premixed insulin are to be avoided by all the type 1 diabetics, and most of us recommend that everyone should go for basal bolus therapy. Truly 3 times bolus therapy and once basal therapy, but rarely you might require 4 or 5 pricks of bolus, maybe 6 o'clock in the morning, maybe 5 o'clock in the evening as an addition. So you have 5 boluses, as well as sometimes you need to go for even twice a day basal therapy. So that's what is, which may differ from one to another. So this is a basal bolus therapy, which I already told you, multiple daily injections with once day long-acting insulin might match the physiology and can achieve a good HbA1c target what you want to have. Now, why to prefer rapid-acting analog over the regular insulin? I feel everyone knows now more rapid-acting insulin. The rapid-acting, when we say, I'll have some more slides on these lines. We have postprandial hyperglycemia is better controlled by the analogs versus the regular human insulins. And sometimes you have a drug which can, now rapid-acting analog may be taken 5 to 10 minutes, 15 minutes before meal. Now when you talk about glulysin, it is to be taken up to 15 minutes before meal and can be taken even up to 20 minutes after the meal. So the total window period is around 35 minutes for glulysin. When you talk about S-part, it is 5 to 10 minutes and maybe 20 minutes or around 30 minutes of the window period. When you talk about S-part, which is faster acting insulin S-part, which can be taken 2 to 3 minutes before and maybe 10 to 15 minutes. So window period is less. So longer is the window period you have, you possibly, and with the same action profile of typically controlling postprandial spikes, might be more simplified way of the life rather than, so you can take it before the meal, in between the meal, and even after the meal. So it simplifies your lifestyle. Are all the rapid acting analogs are same? So rapid acting analog may have differences between in the absorption. Sometimes they may not mimic the physiological profile, may have some delayed actions, may have higher risk of having hypoglycemia if they have delayed actions which is there, and if you have very short window of flexibility of the meal timing, that might also have its impact on the regular lifestyle. Evidences of glulysin. So if you talk about the rapid acting properties demonstrated by insulin glulysin in adults are also observed in the children as in adolescent with type 1 diabetes. A typical, whether it's adolescent children or the children, are almost typical postprandial spike. Now when you take a normal meal, what happens in normal person who's non-diabetic? The peak of the postprandial peak comes typically at 70 minutes. Some papers say 80 minutes, some of them say 70 minutes. And when you take any insulin, your peak should come at around 70 minutes, which will possibly cover the maximum part of the postprandial spike occurring because of your diet. So let us see. This is a data which insulin glulysin is safe in and well tolerated in children with type 1 diabetes. And this is an international observation study around 100 children, 6 to 12 years. And that's called as Occupy study, and that has shown a good safety profile in general with the low rate of severe hypoglycemia and few adverse events, and this has been shown in both the population. Now lower postprandial excursion, this is what I was talking about with the insulin glulysin versus the regular insulin. And this is the insulin level. This is children which is higher initial insulin concentration and lower postprandial spikes when you use the glulysin here. The peak of insulin also taken nicely at around 70 minutes here. You can just observe it around 60 to 70 minutes. You have got the peak here, and the blood glucose, the postprandial spike has been controlled very well versus regular insulin, where you don't have an actual peak here and you have a shoulder effect. This is called a shoulder effect. The insulin, the rapid acting analog insulin action is over by around 180 to 190 minutes, but the regular insulin action is still there, and this is called as shoulder effect, which might have late evening hypoglycemia because of the overlapping action of this is a breakfast insulin, then you take another insulin at the lunch, and then you have a late evening hypoglycemia. Usually hypoglycemia occurs between maybe 4 p.m. to 7 or 8 p.m. And this is a study of 860 patients type 1 receiving once a day glargine along with glulysin, and they have shown that the postprandial reduction was observed to be quite significantly better in the glulysin group, and they have required little lesser insulin doses when it was compared to regular insulin. Insulin glulysin when was compared with the insulin aspart. The area under the curve, if you see, this is the area under the curve, which is glucose infusion rate, 0 to 30 minutes. So you have within 30 minutes you have the action profile on, and the GIR was found to be lower versus in the aspart group, which again shows that the action started early and the action is going to be over better, and so that you have better action profile. And that's why this diagram of postprandial control, this is insulin glargine versus insulin aspart. You have peak early and the mean insulin concentration seen better than insulin aspart even. So both of them are rapid acting analog, but it seems to be better in aspart insulin. And why it is happening? The only reason is that most of the other analogs, whether it's Lispro or aspart, have used the zinc molecule for joining the multiple molecules, monomers of insulin. Now insulin gets absorbed in the subcutaneous tissue in the monomer form. Now they come in the hexamer form. When you inject them, they are in the hexamer form. But these hexamer forms are joined with the zinc here. Now in glulysin they have not used zinc. Instead of zinc, they have used polysorbate 20, which has a faster rate of dissociation into the monomer than the regular insulin or other rapid acting analogues. And that is the difference between the two analogues, that the dissociation in the subcutaneous tissue is faster, and that is why absorption is better. Now there's more children with adolescent with type 1 diabetes achieve HbA1c control when it was compared with Lispro. So we have seen comparison with Aspart, and this is versus Lispro. More number of people have achieved whether it's 4 to 7 years or 13 to 17 years. Statistically significantly higher number of people have achieved HbA1c less than 7. Lower daily total dose of the glulysin compared with Lispro. And that was also found to be statistically significant in around 270 to 80 people. And this again has shown better efficacy, less amount of insulin, achieving better control, and more number of people with HbA1c less than 7. And this is a real world effectiveness and the safety of the people with uncontrolled type 1 diabetes. They have adult with type 1 as well as type 2 diabetes here, and they have seen the primary outcome was the HbA1c as well as the postprandial blood glucose. And I won't go into design of it, but it's a 12 months period, starting with 2 weeks of screening, then baseline, and then the 3, 6, 9 and 12 months, so almost 1 year observation period. And what is the conclusion here is, the switching to glulysin from the regular or aspart insulin or Lispro resulted in improved effectiveness with the 43% of type 1 and around 40% of type 2 patients reaching their individual predefined targets within 1 year period. And the confirmed hypoglycemia was also 5.7 in type 1 and 1.6 in type 2, and there was no case of severe hypoglycemia. So switching over, those who are already taking other insulin, switching over to glulysin seems to have better from this data. Switching from aspart to Lispro to glulysin significantly also reduced postprandial blood glucose after breakfast as well as supper in the children. And this is the plasma glucose level. This is after glulysin, better control, and this again after glulysin, better control, and that was statistically significant whether it's post breakfast or whether it's post dinner or post supper. So need of the mealtime flexibility is important. So meal management of the type 1 diabetes is difficult. It's sometimes difficult whether because of their behavioral issues, that you take the insulin but you don't take the meal, or you take the meal, don't take the insulin. Something like this always is going to happen, and every mother realizes it many times. So do children need the more flexibility, especially the window period of meal timing or the insulin? So you have the 15 minutes before and 20 minutes after the meal. So have a window period of around 35 minutes when you use glulysin versus the other insulin. If you talk about aspart, the total this 5 to 10 minutes before meal here, Lispro 15 minutes, and the total and then newer aspart 2 minutes. So the total window period with glulysin is 35 minutes. With Lispro it is not available, but the newer aspart is 22 minutes. That you can take it after 20 minutes. So 20 minutes post meal is here similar, but here it is 15 as 2 minutes. So you have an additional 10 minutes here as a window period to take insulin. So when meal is planned in next few minutes, unexpected things can delay. As this I already told you in injection technique, especially in children who are adolescent or small children. How glulysin differ from Lispro and aspart, and that's the unmet need. It mimics physiological bolus insulin better, faster absorption, early metabolic control, lower daily doses, and maximum window or flexibility of taking the insulin. Insulin glargine plus glulysin in type 1 diabetes and basal bolus therapy. So there's one should always not prefer the premixed insulin in type 1 diabetes because of the various reasons. Premixed insulin do not mimic the physiological profile, and it could be a problem, and that is why basal bolus therapy has to be preferred. It's an important combination of glargine with the bolus insulin. It can have a fasting as well as postprandial control better. Insulin glargine provides a continuous peakless basal insulin profile for 24 weeks or 24 hours. Insulin glulysin have a better postprandial control. Switching from the previous insulin, if you switch over to glargine and glulysin, from this slide it says it seems to have better control. In the real world data, it is shown to have its efficacy as well as safety. So better treatment satisfaction from the the DTSQ. There's a kind of questionnaire which actually shows you whether the therapy is satisfactory or not, and it has shown better satisfaction with the treatment satisfaction when you use the DTSQ questionnaire when you are using the glargine and the blue-lysine combination versus the other ones. So insulin glargine blue-lysine, the most studied basal bolus combination, have shown that adding blue-lysine bolus to glargine basal therapy achieved good glycemic control and is well established to be more convenient, and safety profile has also been proved. So maximum number of clinical studies in this combination, you have 1, 2, 3 usaries, which was and multiple trials they have. Benefits of the switching over is significant improvement in glycemic control, low incidence of hypoglycemia, better treatment satisfaction, and improving quality of life. Can we use blue-lysine in insulin pump? So there are some trials where it has been found that blue-lysine may be used for the CSI or insulin pump in many, almost everyone. Due to specific molecular structure, blue-lysine is formulated without zinc and has been added with the polysorbate 20. So zinc-free formulation induces more stable monomers and is therefore suitable for use in the pumps. And this polysorbate 20 prevents the fibril formation. This fibril formation is associated with pump catheter occlusion. So chances of having pump catheter occlusion with blue-lysine seems to be less. Of course, we have to have a good data available in the comparison of using one versus other. We don't have such head-to-head data available as far as the pump catheter blockage is concerned. Similar glycemic control and safety has been observed in the blue, whether you compare blue-lysine versus aspart versus Lispro, it was as far as use in insulin pump is concerned. Blue-lysine versus aspart with respect to unexplained hyperglycemia and the catheter set occlusion. So you have some data here. Blue-lysine, very small number of 30 patients here and 30 patients in aspart. More than one catheter occlusion seems to be less here versus almost half here versus aspart. 0 to 1 catheter occlusion per month percentage wise again seems to be less. At learn one unexplained hyperglycemic episode seems to be half of it. Number of the experience more than one episode of symptomatic hypoglycemia almost similar, and experiences more than one experience of severe hypoglycemia almost similar. So blue-lysine can be safely used even in the pump which is in type 1 diabetes. So to summarize, Archana, you can have counted it the minutes. I feel it's less than 15 minutes. Basal bolus therapy is the standard of care in type 1 diabetes. Insulin blue-lysine offers a faster acting action profile and better than regular, effective postprandial control with maximum window of meals of flexibility. Insulin glargine and blue-lysine combination is effective and well tolerated. To summarize further, a unique benefit is early onset of action, which mimics a physiological bolus insulin. Maximum dosing window of 35 minutes, greater glucose disposal at 1 hour, so you don't have a shoulder effect in the evening, and more patient reaching HbA1c target versus Lispro. With this, I stop here. Thank you very much for patience. And I